Now moving on to our next topic, countermeasures implemented by Taiwan Adventist Hospital in response to COVID-19. Dr. Chue, you may now have the floor.
Okay, first of all, it's great to see a lot of friends, especially from Guam and Saipan. It's nice to see that everyone is doing well. We know that in the current situation, everyone is doing hard, coping with the hard situation right now. In the chat, people were asking about the files, the PowerPoint files. We will be sharing that by email. In PDF format. So if anyone wants these PowerPoint files, just leave your email in the chat and we'll get to it sooner or later. Okay, so my topic is about coping with COVID-19 in Taiwan, especially from the angle of a hospital. So there's public health, there's government reactions, but there's also hospital reactions that should be done to cope with COVID-19. So first, a very brief introduction of our hospital, the Taiwan Adventist Hospital. It was established in 1955 under the Adventist religion. So this is actually an American hospital that is part of the Adventist Healthcare Association. So we have friends from Loma Linda and White Memorial Center in this conference as well, all part of the ACA system. We are not a very large hospital, I would say moderately sized. We have a total bed number of 389 with 128 physicians, 15 dentists, 139 medical tech, around 450 nursing staff, and 337 other staff. So the healthcare system in Taiwan is not completely same as the States. So for a simple and rough comparison, we can have the Zuckerberg San Francisco General Hospital as something to compare with. This, according to their institutional master plan updated in June 2015, they have 403 acute beds. They are a level 1 trauma center, a staff of a total of 4,250 employees, and they account for 20% of all inpatient care in San Francisco. Taiwan Adventist Hospital has a total of 1,077 staff. Now, for services provided, ambulatory specialist clinic visits, our hospital has around 38,000 per month. San Francisco General has 17,000 per month. Surgeries, we perform about 860 per month. San Fran Gen has about 606. For inpatient hospital days, our number is a bit lower, 4,800 hospital patient days per month, compared to 6,200. For length of stay, our average length of stay is 4.1 days per stay. For San Francisco General Hospital, it's around 5.2. ER visits, our numbers is about 1,600 per month. For San Francisco General, that's 8,500 per month. Babies born in our hospital, around 109. For San Francisco General, that's around 95 per month. Now, these numbers tells us that we are a mid-sized hospital that is not running with as many personnel as a hospital in the States. So to be summarized, we are a mid-sized hospital right in the center of Taipei with a lot of medical centers around us. The special part of healthcare in Taiwan is that we have single-payer universal healthcare. And our hospital is well known for taking care of international patients, which is a problem during the COVID-19 pandemic, since everybody is afraid of people who are not from around them from around the area that they're used to. So as the responsibilities as a hospital during the pandemic, we feel that first of all, actually in no specific order, protecting our staff, screening and treating for COVID patients, but also at the same time caring for and protecting non-COVID patients. The goals that we've set in the beginning, first of all, absolutely no in-hospital COVID outbreaks, and hopefully no missed COVID patients. So there might be a patient with symptoms that come to our ER. We hope that we are able to catch that patient so they won't be returning to the community and spreading that disease within the community. And also we want to continue providing health care to non-COVID patients, even including elective procedures. Now our mentality toward fighting COVID, that started from the SARS epidemic of 2003. Now, that was a very tragic event for the society of Taiwan, especially the medical community. So ever since that day, 17 years ago, we have always been preparing for the next big one. And due to the geopolitical situation that we unfortunately are in, we always knew that we were sort of somewhat on our own. We were never counting on the help of the WHA or the WHO. So in order to combat that, we had quick reactions. And when we were implementing responses within our hospital, we always cared about fairness between patients, between the employees. And since we couldn't trust any international organization, we were always trusting the government. And we did not want to become the weak link within our community in Taiwan. Also, we did not want to become the weak link within the international community. So our responses can be divided into organizational, space allocation, personnel, communication, innovations, and also donations from the private sector. Organizationally, in early January, our hospital started the Taiwan Adventist Wuhan pneumonia, politically correct COVID-19 response team. It started in early January with the members you see mostly here in this room, led by the President Huang of the hospital, and also the speaker before me, Dr. Yang, who is the Vice President of Medical Quality and also in charge of infectious control and infectious diseases in our hospital. So the members of this response team included all of the top management in our hospital, and we had weekly social distance meetings, also with a real-time chat group. For space allocation, we wanted to create a COVID treating hospital within a non-COVID hospital. That means patient diversion starting from the front door, such as this is the waiting area of our emergency department. You can see it's divided into fever and febrile waiting areas. Now, temperatures were taken for all people entering the hospital. 17 years ago, we used to have that infrared temperature taking machine, but 17 years later, when we removed it from storage, it was no longer working, so we purchased the new one. Whenever a visitor to our hospital or our facility steps on within this orange square, their temperature is taken automatically. If they have a fever, then there will be an alarm. Now, we now know that travel, occupation, contact and cluster history, TOCC, is extremely important because there are asymptomatic patients who are capable of transmitting the disease. So TOCC's history is taken for all people that are entering the hospital. That includes visitors, patients, even people from medical supply. Now, patients with fever, COVID-related symptoms, and positive TOCC are diverged. They do not go the same way that non-COVID patients go. They are first diverged outside to this tent area. And as you can see, our hospital used to be a hospital known for its elegancy, a place, a very comfortable healing place. These tents outside do not have that same feeling. So during this pandemic, we've chose for fast, quick solutions, good enough solutions. We did not have the time to care about the aesthetics of these tents. And the patients were diverged outside to the tents. Inside these tents, there were testing areas for swabbing and also for portable X-ray. Confirmed and suspected patients were sent to a designated COVID floor. Before the outbreak, our hospital only had 3 negative pressure isolation rooms. Within 3 days, we had a whole floor readjusted to be negative pressure. Now, the ability to do that was actually because after 2003, the SARS outbreak, our hospital, in the back of our mind, were always preparing for that. So there was always the capacity for us to have a shift for a floor to be changed into negative pressure by changing the air conditioning, some settings on the air conditioning systems. Now, as I said, again, they were just good enough solutions. But when we're dealing with a pandemic that moves so fast, good enough solutions are good enough. Then the non-COVID internal medicine patients, as we said, we wanted to continue caring for non-COVID patients. They were reallocated to the pediatrics ward, which is quite a cute place, as you can see from the picture. Now for phase 1, on that floor, we first had a green area and a red area. Non-COVID internal medicine patients were still treated here. And this area was changed to a negative pressure area where COVID patients or suspected COVID patients were treated. There were no crossover between treating personnel, nursing staff, and even patient walking flow of these 2 areas. But very soon, because of the dramatic surge in confirmed and suspected patients, we shifted to phase 2. Phase 2 was actually even easier for us because then the whole floor was then changed to a COVID ward. So on both sides, these are negative pressure wards. The positive pressure wards and these on the side are working space, resting space for the staff that are treating the patients, which is the clean area. We had very clear divides to make sure that nobody was crossing the barriers that was made. So as you can see, this is a man-sized poster telling people that this is a regulated area. I feel that any person who mistakenly walked onto that floor after seeing such a large poster would likely be leaving that area. For personnel, we had total involvement of all staff. That's all hands on deck. So first of all, for social distancing, also to add personnel to the workforce, we had closure of the hospital gym and cafeteria and reallocated the personnel for them to do different tasks. And also we had very good transparency of tasks and expectations. So people who are having their everyday workload shifted around, were knowing what they were getting into, and were knowing what was expected of them. And we always wanted to avoid crossing the COVID barrier if possible. So for nursing staff, they had complete separation. Nursing staff that were taking care of COVID patients or suspected COVID patients did not go back to treat non-COVID patients. But for doctors, since, as I said, we have 100 or so doctors, we do not have enough doctors to have complete avoidance of crossover. But we tried to avoid it as much as possible. And when treating suspected patients, we had the proper PPEs. And also, In the SARS outbreak from 2003, we found that a weak link inside the hospital is often the janitorial and supportive staff. So starting from then, and especially recently, we had very extra education for the janitorial staff about safety measures, cleaning measures, how to protect themselves, because by protecting themselves, they are protecting the whole hospital. For personnel, even though COVID-19, of course, is an internal medicine infectious disease, this is the responsibility of the whole hospital, not just the internalists. So all full-time doctors under 55 years old were assigned to rotate on duty night shifts for the COVID ward. Now, 17 years ago, we had a problem when doctors came out and said, I'm an eye doctor. Personally, I'm a urologist. I know nothing about internal medicine, so I do not want to treat any COVID patients. I do not want to treat any SARS patients. But our government actually was preparing for this. So after the SARS outbreak, we had national general healthcare training for all specialists after SARS. So all doctors within our hospitals and all doctors in Taiwan do not have that excuse saying that they do not know, because they have received general healthcare training. And also, the hospital provides survival guides for COVID duty doctors. So it was it was a guide for doctors to know what to do when, if, and what kind of situation came up, and also who to call, what to do. So they were not left there helpless. For personnel, an important thing, everybody is, of course, is worried if there's infection of, if a staff member is infected, that would cause an in-hospital outbreak. So there always has been a health status report system within our hospital. A doctor or a nurse has to report to our infectious control center to tell them if they feel any cough, any symptoms, any fever. After the pandemic, we had very thorough implementation of this staff health status report system. And if an employee had symptoms, then they received testing and isolation. All hospital staff were tested if they had any related symptoms. I'm happy to report that in our hospital, there were no confirmed cases within our employees, but they only returned to work after they had negative test results. Communication, when dealing with this kind of pandemic, communication is very important. That's between other hospitals, learning from peers. That's with our staff. That's with our patients. That's between the government. We had a lot of online chat groups with administrators from other hospitals, learning what they're implementing, learning what they're doing, how are they coping with this pandemic. With our staff, so we need very direct communication with our staff, finding out the needs and the places that are vulnerable. So that way, the decision-making is made from bottom up instead of top down. The observations from the front line are the most important. And also with our patients, to help our patients understand that if they are COVID or suspected COVID, they will receive the proper care and no discrimination. But also for non-COVID patients, to understand that since we have this divergence of patient flow, that they are in a safe environment, even though this is a COVID and non-COVID hospital at the same time. And in blow letters between the government. So for patients and family, we had to tell them that the TOCC, the Travel Occupation Contact and Cluster check at the front door was mandatory. If they refuse the check, that's no entrance. And we have to thank the government for this. This TOCC check is with our national health insurance and also with our border control. So if they provide any ID, such as an national health insurance card, residential card, or ID card, we can use this ID card to see if the patient has returned from abroad. So if it shows a yellow warning sign, then it would be saying that this patient has just came from a certain country and entered our borders at what date. And then, as the pandemic became more serious, only a single TOCC check accompanied family member is allowed, and there are no visitors allowed in this hospital. A surgical mask is provided to each in-hospital patient by the government, and also another surgical mask for the accompanying family member, also provided by the government. So trust, trust, trust. When we're working against such unknown problems such as this virus, trusting the government and what the government is saying is very important. So that's why information transparency is such a big thing. From an editorial piece in the New York Post published, opinion piece published on April 25th, 2020. These words actually resonate quite a lot with me. So Taiwan makes sure that its health institutions are hyper-vigilant about epidemic risks after the SARS epidemic of 2003. If a threat is detected, containment plans and supply stockpiles are ready. The process starts at the bottom, not the top. So the same thing happened here in our hospital. Most things were done before official regulations. When we started hearing the rumors about an unknown virus somewhere in China, we started renting the tents. We started having the response task force meetings. These things were done before official regulations, and this was almost at all hospitals. So the hospitals were moving as soon as there were rumors. We were doing what we thought was right, and we were trusting that the authorities would support us later. Innovations. So usually our chronic patients have their prescriptions refilled at the pharmacy inside the hospital. But we thought that since these patients are patients with underlying disease, they are the patients that are most at risk. So we had this door that actually is the door leading out to our parking lot, changed into an outdoor counter for patients to not need to walk into the hospital and receive their prescription refills. Now this is just a small innovation, and as you can see, these boards and the acrylics are not that aesthetically pleasing, but as I said, good enough solutions are good enough. Now, as I said, we are right in the center of Taipei, so we are very spatially challenged. Everybody has to eat. So this is in the OR. When the staff in the OR are eating, the nurses had a very smart way of implementing social distancing during lunchtime. So we had ways of social distancing in confined spaces. Also, all non-essential meetings were canceled or changed to online conferences. For isolation patients, we want to care for them, but each time going in to care for them or to chat with them or to talk with them is also a risk of contracting the disease. So quick video surveillance installment in all isolation rooms. And a good thing that Taiwan is a very high-tech country. So all we need to do is go outside and buy some webcams, and we had the consent of the patients, and then these were quickly installed within the isolation rooms that we made on the whole floor, and it could be seen from a central monitor within the station. Also, it could be seen with the smartphones from our hospital. But of course, this was all under patient consent. Now, a very large issue is personal protective equipment. Now, that includes protective face shields, goggles, hairnets, gloves, protective gowns, surgical masks, N95 respirators, full body protective suits. Surgical masks, N95 respirators, and full body protective suits are regulated by the government. The rest, according to government law, we have or had 15 days of stockpile before the pandemic. We have been lucky enough to not have a shortage of this, so all of our frontline doctors and nurses have very adequate PPEs. And also that comes to trust, especially with surgical masks. That is completely regulated by the government, but they told us to use these masks as needed, and they will replenish it if we have a shortage. Now, we started with significant stockpile and supply, but we still had very careful management of PPEs after the outbreak. There always is an ongoing struggle between safety and conservation of the PPEs. The government did provide very specific guidelines for different situations. So when interviewing a COVID patient, or when doing invasive procedures, or just chatting with them, the guidelines for PPE are different. And even our guards. So this is a security guard at the front door who has been working very hard recently, helping diverge the patients. They also have sufficient PPEs. Now, in our hospital, we did have the innovation of, and also hospitals all around Taiwan, using acrylic shields of all types. So for an information counter, that's covered with an acrylic shield. For intubation, there's that innovation of an intubation box. But unless we face the real shortage of proper PPEs, the unproven acrylic shields will only be for added protection. So we still like to go by what's been proven, what's been recorded by medical literature to be correct protective equipment instead of the innovations. Now, if we do come to a shortage of PPEs, then we must rely on those innovations. Before that, we still have them, but we hope that we will still be able to use the correct PPEs. Testing has been a question all around the world. Testing here in Taiwan is centrally regulated. So it is done always by RT-PCR, but not in our hospital. We have the samples collected and sent to the Taiwanese CDC, and then they will then allocate it to qualified labs. The result usually returns in hours, within 1 day. Now, the regulations for testing has been adjusted according to the pandemic. So that's been rolling adjustment of the criteria of testing. Testing capacity in Taiwan has been increasing daily during the pandemic. Government testing regulations started from patients only with related travel, occupation, cluster, or contact, and then to highly suspected cases with or without related TOCC. Now to any patient that is clinically suspected or with pneumonia. But in order to conserve the testing capacity, the general public cannot ask for a test for no reason. They can come see a medical specialist. Then the medical specialist will use their expertise to determine if they clinically suspect or do not suspect that patient to be a COVID patient. If they suspect it, they can then order the test. If they don't suspect it, they will save that resource for patients that really are suspected. Now, this is a testing booth that is also innovation from our hospital. After the suspected patient is inside, we close the door, sort of like a telephone booth. Maybe some people still remember what are telephone booths. And the hole over here and the hole over here is where the doctors are able to put in their hands and then give the test. That way, if the patient sneezes or cough, they will cough towards this way, and it will be sealed within. But as I said, this is not a proven method, so this is only for added protection. We also were very lucky to have donations from the private sector. MediaTek, a very famous Taiwanese semiconductor company, they donated 2 very expensive UV disinfectors to our hospital to help us disinfect our rooms to protect our staff and also protect the community. Also, many businesses and people who prepared meals for our staff to express their support. And it was very heartwarming to see the community expressing their thanks to the people on the front line. Now, that was all good things, but actually, of course, like all people, we faced quite a lot of difficulties. Reasonable and fair allocation of PPE to different units. Having non-internal medical doctors and nurse practitioners help share the load. So as I said, this is a problem for the whole hospital, but for some doctors or some nurse practitioners, they will feel that this is an internal medicine problem. And then we had to use a lot of communication and also with guidelines, survival guides, to help them to be able to help share the load. Also, Taiwan is a place where there's not a lot of space. The center of Taipei is also a place where space is at a premium. So our hospital, though, is very spatially challenged, a very polite way to saying a small in space. But in that spatially challenged hospital, we tried hard to diverge our COVID and non-COVID patients. So as we can see, this yellow line on the floor, if there were COVID patients inside, that becomes a barrier that patients are not able, that our employees are not allowed to cross. These red lines on the floor are if the patient that is suspected to have COVID-19 needs a CT. They are sent from the emergency department to the CT room. They will not leave the red lines. That way, when we are disinfecting afterwards, it will be easier. When patients are transferred from the COVID ward to our negative pressure ICU, we also noted that even though the correct SOP has been written and we know the correct SOP, but doing it in real life caused a lot of problems. So afterwards, we had a rehearsal. And this picture is quite important to me. So after the rehearsal about how to send the patient from the COVID ward to the negative pressure ICU, this is our cleaning staff. This is a guard to help control the elevators. This is a RT in charge of the ventilators. That's me, a doctor. This is a nurse practitioner. These are the nurses. So as I said, this is whole team involvement. For a patient to be moved, that's the whole team that needs to become prepared. And then our hospital is not a medical center, so we did have patients become more severe and needed a transfer to the medical center. And then we needed our authorities, local authorities, to help us arrange for a transfer. That were some of the difficulties that we faced. In conclusion, I feel that total staff involvement, transparency with good communication, bottom-up decision-making, simple, good enough solutions on time were the things that were most important for our response. The fight is far from over, but through cooperation, I think we can have better results. Thank you.
Thank you very much, Dr. Chue.